probe. Designed from the ground up for precision surgery, its high-sensitivity detection crystal delivers unmatched accuracy. With a modern probe and tablet, Gamma Pro is simple, intuitive, and easy to use. Sterilization is simple and safe. Compatible with 9 different isotopes, and capable of detecting 3 isotopes simultaneously.
There's only one name you need to know. It's CupTech.
Welcome back to the Mood Food Podcast, where food, science, and the human spirit come together for healing. Today's guest is someone whose work has touched thousands of lives. We are joined by Dr. Ashutosh Kothari, one of the world's most respected oncoplastic breast surgeons, who was the clinical lead of the academic breast cancer unit at Guy's and St. Thomas's NHS Trust in London. Dr. Kothari leads one of the busiest tertiary referral centers in the UK. He chairs multiple breast cancer leadership groups, teaches globally, mentors future surgeons, and has led first in-man clinical trials exploring new imaging technologies for breast cancer. He also plays a key international role, serving as the European representative of the Indian Association of Surgical Oncology and contributing to clinical development and surgical collaboration at Reliance Foundation Hospital in Mumbai, where he is Director of Breast Surgery at one of India's leading centers for cancer care. His expertise spans hereditary breast cancer in young women, and immediate oncoplastic reconstruction, and his work continues to shape the future of breast cancer care worldwide. Dr. Kothari, thank you so much for being here with us today. Dr. Kothari, we want to begin with your journey. Before you were Dr. Kothari, the surgeon, who were you as a young person? What part of your life, early life, shaped you, or as a surgeon today?
So, a young Ashutosh was born in Mumbai and did my science qualifications also in Mumbai. And then my mother, who was a doctor and working in breast cancer research at the time, was always my motivation for becoming a surgeon. So she was an endocrinologist, and I was always interested in surgery. So I took medicine, and then I did surgery in Mumbai, and then I did super specialization after general surgery, spending 6 years in the Tata Memorial Hospital pursuing general surgical oncology. And while doing this, I noticed that there was the breast cancer field changing quite rapidly. So there was a unique blend in breast cancer of precision oncology and creative surgery. One of the few subspecialties, I would say, where we combine oncological safety and aesthetic excellence. And it demands both technical skills and thoughtful planning. You have the opportunity to interact with these incredible women who go through these journeys with smiles in their faces. And most importantly, why breast cancer is because it was the most rapidly evolving, changing field at the time when I was developing as a young oncosurgeon. There were lots of things coming in. Breast conservation surgery was coming in. Sentinel node biopsy was coming in. So the science was evolving really rapidly. And that's what got my attention, being inquisitive by nature. So it was a mix of all these things that got me to breast cancer.
Wow, that's quite an amazing journey, starting with your mom and then into all the new developments.
Well,
Dr.
Dr. Kothari, this was quite amazing journey that you've gone through. Is there any example or things that you learned from, say, your patients? Any kind of thing that changed your thinking about how you would proceed in your medical career in a way? A story about a patient whose journey changed the way you practice forever? Things that were really, or an operating room where something happened that changed things in your life.
I think what changed my bravado as a surgeon and brought humility in my life was interacting with young women. Young women as young as 19, 21. I remember my youngest patient being 19. And she came to me with de novo metastatic disease. So she was stage 4 at diagnosis.
Wow.
And at that time, we had Herceptin just breaking in. So the HER2 antibody had just broken in. And I remember telling her, I'm a bit guarded about how well you're going to do. And this young girl had a big smile on her face and said, Ash, do your best, and I'll do my best, and let's see what comes in the end. And then Herceptin worked its magic, and she went on from being a 19-year-old to a 26-year-old. And through that, I learned that you can't predict outcomes. And there is something there besides science that drives tumors, patients' will, her willingness to beat the cancer, her willingness to survive, and her smile on her face throughout. It taught me a lot of things about how to tackle young women, and that's why I developed an interest in younger women, because what we're doing effectively is kind of putting a pause in their life. They've come with all this gusto and bravado, and they want to do these great things with their life, and suddenly we come and say, hang on, you need to listen to us. You need to take a break. And now I realize that we don't need to do that. So the learning for me was, yes, I'll take a part of your life, but I'll try and give you your life back. And that's what I endeavor to do. I try and say, okay, a brief holiday where you spend some time with us and in an unfriendly environment of a hospital. But then we'll try and give it back to you in such a way that you go back and integrate into mainstream. And this was just a speed breaker and not kind of a brick wall.
And that was pretty convincing.
Because that was actually, I still remember this girl, and she is, unfortunately succumbed to the disease, but she had a great 8 years, having told her that you probably have 8 to 12 months to live at diagnosis. And I think it was quite humbling for me as well, because we were wrong. And she always said, I'll prove you wrong. So I've learned one thing is we try our best, the patient tries their best, and what will be, will be.
It's true. That is true.
Yeah, I think that's kind of, the lesson everybody has to understand, that we cannot tell people that this is going to be fatal and you're going to be done it within a year, when it depends tremendously on a person's attitude, how they kind of perceive this and how they go through the treatment and eventually come out of it. So that's a fantastic way to think about it, and also great example to see for a lot of people who think this is the end of the world for them. So I wanted to ask you also, is what are some of the unique challenges that you face when you're treating younger women?
Yes, it's a very different challenge with younger women, because breast cancer usually affects women in their 50s, 60s. And when we say young, the definition keeps changing, but because we're now both mentally and physically doing quite well, I think young is 40 and below. That's what we classify as young. And so because most people will think young is 20s, but there are a small number of patients who are in their 20s. So we're talking about women who are otherwise fit and well, who are breezing through life, have a career, probably have a family or planning a family. They have a career which is just developing, evolving, and probably taking hold and going in a particular direction. They are in a relationship or are in a marriage. Either they have a family or they're planning a family. So we have to mix profession, family, values, relationships, intimacy, the need to have more children. It becomes, you're juggling so many balls that it becomes a unique challenge to get all of them and keep them all up in the air and keep the patient happy. It's not just, that your body will change, because these are scars, and we tell them that, yes, appearance is important, especially today when the whole world is living through Instagram and Facebook. So appearance is important, but wear your medals with a smile, because hair loss, scars, these will diminish with time. Also, because you have work, it's good to tell them that they can speak to HR, they can speak to their managers and ask for flexibility at work. So you don't have to compromise, or they don't have to sacrifice careers. They can decide who they want to share the news with and how much they want to tell. So they control the narrative rather than being told all the sad stories that happen to friends and relatives, because everyone's an expert when it comes to giving advice.
Of course.
Advice is free.
Of course.
And you always hear the bad stories. You hear the things that went wrong and how someone didn't do well and how someone didn't respond, because the people who actually do well just get on with their lives and don't talk about it. So I think what we need to especially keep in mind is they need to be gentle with themselves, honest with what they need, voice their wants, their concerns, their needs. Unless they don't put that out in the open, we won't know what is important to them, because we will then prioritize that and try and tailor our treatment around and encompass all their needs, so that at the end of their journey, we maintain their fertility. We try and give them a semblance of, or at least as much as possible of body image confidence, give them advice about intimacy, about how to proceed if they have problems, because some of them will be on hormonal treatment, about pregnancies. So we need to look at lots of things, including fertility in these women. And that's why it's not easy just treating the cancer, because we need to treat the cancer, but we need to keep in mind that there are all these other factors which are more important to them, because they want their life back. They want to have that ability to control the narrative. And that is why it becomes slightly more tricky when you're dealing with younger women with breast cancer.
Well, I have a question. Now, I need to understand, I think I would like to understand how you fit in the surgical scenario as a oncoplastic surgeon. Where does that come in?
So I think the first thing what we need to remember is, although it's a multidisciplinary team and the approach is very multidisciplinary and all encompassing, the front of house, the person that is constant throughout this journey, is a surgeon. So the patient is referred to a surgeon, and then the surgeon kind of leads the team. So that's where my role comes in, as probably a team leader, or at least an important part of that team, because the patient, I'm front facing, I'm front of house. That's what the patient constantly comes back. I'm the constant that it circles back to, from oncology, from radiation, from imaging.
Mhm.
She'll circle back to me and ask me for advice. Then there is the evolving or the new field of oncoplastic surgery. So I think, when I remember still in 1999, when I was training in the Tata Memorial, we used to rock up for surgery. It used to be, all right, which breast are we doing, left or right? And the surgery was one. It was a mastectomy.
Mm.
And then we evolved to, okay, in the early 2000s, let's save the breast and do lumpectomies. But we were not giving great results, because there was, intraoperative radiation, there was brachytherapy, there was a lot of radiation being given, and we weren't reconstructing the defect that we left behind. And then it evolved to the whole oncoplastic thing, where we had the cancer being treated in all its oncological safety, but we brought in principles of plastic surgery to maintain the aesthetics of the breast. So not only were we giving them a lasting, wholesome cure, we were also giving them confidence, breast contour, body image confidence, and the ability to dress the way they wanted, without asymmetry. When they looked in the mirror, we didn't want them to remember that part of their journey which was hurtful. We wanted them to look forward and say, wow, I look great again. And this is where I think a surgeon, especially an oncoplastic breast surgeon, plays a very pivotal role, is planning the right surgery, then delivering it, or technically executing it with great finesse, and finally giving the patient back what they came with. And that's the challenge. And that's where I think surgery today is playing a key role in giving back the smile to the patients, where the journey of the surgery, the scar, is not a reminder of something that went horribly wrong, but something that was a positive experience.
That's a huge responsibility. And you're with them from the very beginning.
We are.
Okay.
So, like I said, they always circle back to us unless they progress to stage 4 cancer, where we have to pass them on to oncologists. But
Right.
today, because of the treatment that we've got and the breakthroughs and the drugs coming through with immunotherapy, with targeted therapy,
Right.
with drug conjugates, people are doing really well. The aggressive cancers are no longer the aggressors that they were. We've tamed a few of them,
Okay.
and we continue to tame them. So unless they become metastatic, where we pass them on to the oncologists,
Right.
they will stay with us. And even when they are with the oncologists, I know my patients always come back to me and said, my oncologist is saying this is what you should do. Do you think I should do that? And that's where we play a role, because they've had that partnership with us.
Correct.
From the happy days. So those continue through the days of when things are not going their way.
Yeah.
And they will always maintain that trust. And I think it's a fantastic privilege to have.
Right.
When women actually entrust their decisions to you, or at least bounce their decisions off you. And
Correct.
that's that kind of relationship is not seen in other cancers, where the bond is almost inseparable.
Right.
Till the end.
Right. So you have a major role to play in their whole journey, essentially. So they develop
Yes.
a very close relationship with you, and it becomes one of trust throughout.
Absolutely.
It's pronounced Cubtech.
Cubtech?
CubeTech.
CubeTech?
Cubtech?
CubeTech.
CubeTech.
CubeTech? No, I'm kidding. They just told me that. Okay, Cubtech.
Cubtech. Cubtech.
It's pronounced Cubtech.
It's Cubtech.
When it comes to specimen imaging, there's only one name you need to know. It's Cubtech.
So do you have a team of people that work with you?
So, like I said, a team makes the dream work. Breast cancer is now a well-recognized, multidisciplinary, multimodality treatment approach, where it starts with good imaging. So, right at the outset, you need a good radiologist to interpret those images, to detect cancer early, to detect it accurately. The extent, is it in one side, is it on both sides, do I need more imaging? So you need a good radiologist, you need a good breast care nurse, you need the breast care nurses who are the pillars. I would say that they're more important to the patients in terms of buddying up than the breast surgeons are, because the first question always goes to the breast care nurse who sits with us at the time of diagnosis. And we usually have a couple of breast care nurses allocated to a patient. So if one is off sick or one is not there, the other one will take over. So the breast care nurse links up and plays like a patient advocate, is a patient link between the patient and the institution. That's us.
Mm.
So there is someone who's a friendly face, someone who can call by first name and just say, Ash, let's do this. Or I need to see Ash. Can you fix that up for me? So that is an important role. And then of course you've got the surgeons, you've got the anesthetists who give fantastic plain blocks and regional blocks so that you have enhanced recovery. And then when the patients come back, you have the physician associates who look after their wounds, who look after their drains. You then have the multidisciplinary team that sits down. Geneticists may be involved. Physiotherapists are definitely play a pivotal role, because I believe that exercise and physiotherapy actively during the active treatment, and now more and more evidence emerging about chemotherapy and physiotherapy, radiotherapy and physiotherapy, how it kind of numbs or dumbs down all the negative side effects. So you've got all these people, occupational therapists, physiotherapists who come in, lymphedema specialists who teach you all the exercise. Patients always feel, oh, my arm feels heavy, maybe I've got lymphedema. So we send them off and get the limb volume measured, and the lymphedema nurse will reassure them to say, look, it's all fine, because we always take baseline measurements. And then at the end, you've got the clinical psychologists who also play a role. And I think what is even more important is part of the team is the family, because we always forget that husbands don't know how to react.
True.
They worry. Partners don't know how to react. They just They're either silent and just supportive, or then they're overdoing it. And I think what we did at Guys was something remarkable, where we offered support to the partners. And you'd be surprised how many partners came forward and said, right, I want a bit of that because I don't know how to deal with it. And women are going through chemotherapy. They have hormonal changes. They're probably going through early menopause because of the chemotherapy. So there's a lot going on in the background, which partners don't understand. As a clinician, I understand why she's suddenly moody, or she's a bit short tempered, or wears a temper on her sleeve. The partner doesn't know. So it's important that part of the team is getting their team involved as well. So their team becomes part of our team, and then we work towards the one goal, which is the patient. So it's a huge team effort that goes into making a patient go from being a breast cancer sufferer to be a breast cancer warrior and a survivor and beyond. Now, I always think survivor is the wrong word. You've beaten breast cancer, so you should be, you should celebrate that victory rather than call yourself a survivor, because you've not survived. You've just gone back and got your life back. So it's a huge team effort, and everyone plays an equally important role. It used to be, surgeon-led, always, big egos, big personalities. But now we know that it's not one modality or one specialty that kind of rules the roost. It's everyone putting in their little bits and pulling in one direction.
Bravo.
Thank you.
That's very well said.
Yes.
It's describing such a difficult journey in such a positive way. I also wanted to just, kind of ask you, how do you kind of tell a young woman, this is, you can have breast conserving surgery versus mastectomy, because that's a huge deal.
So, very good question, because, people often equate breast cancer diagnosis to inevitable loss of the breast, aggressive treatment, probably mortality. So my simple technique is I tell the patient everything she needs to know, where we will make a patient come to a decision through what I call a shared decision-making process. I will explain things in small, bite-sized, simple language, slow things down, because the minute you say the C word, some people stop listening. They've gone, you've lost them. You can see it in their eyes. They're far away. They're thinking about family. They're thinking about, oh my God, what happens next? So you've lost them. So then you need to first bring them back into the room. You need to reassure them. You need to have time. It's not a rushed consultation. They need to feel that they can sit there, just stare into the void for a few minutes and then come back to you. Or if they need to, they can shed a tear. They can have a bit of a sob. It's perfectly normal. I think that's normal. I would worry about a patient who smiles there and says, right, bring it on. What do I do next? If someone displays normal emotion, I think that for me is the first sign that we're getting somewhere.
Right.
And then it's breaking things down and trying to explain that I am here to support your decision. I'll put the cards on the table. I'll guide you in a particular direction, which is safe. So my choices will be oncologically safe. Your choice has to be based on your values. What is it that you want? What is your perception? So some people unnecessarily worry about the other breast. And in the US especially, there was a huge wave of having the contralateral breast removed at the time of a mastectomy, with no prognostic benefit at all. But that was because the perception was there that, oh my God, I've got breast cancer once, I'll probably get it again.
Right.
So I don't want to have this, again. So trying to dispel those myths, slowing things down, handing the narrative back to them to say, you're in control. I'm a support actor. You decide what is important to you. What kind of surgery is it that you want? Do we want to preserve form, function, confidence, body image? Or do we want to go down the more ablative way of a mastectomy? And some patients, you'd be surprised, the younger women, in my experience, always choose a mastectomy. The older women want to have breast conservation, which is actually contrary to what you would imagine. Because I think the younger women think of their long arc of survival. They think, okay, I need to live to like 90. I've got 60 more years left. I can't have this thing coming back. So let's just get rid of the organ. The elderly women are a little more, I think, perceptive in their considerations,
Approach,
and they
yeah.
think, okay, I can have a lumpectomy, I'll beat this thing, I'll be fine. So it's empowering. Coming back to your question, it's empowering the patient with information to make the right decision, which may vary and might surprise you. But I think at the end of the day, provided you go through a nice process of shared decision making, where there is a breast care nurse who goes away and then comes back, if I find that a patient is struggling, there is no pressure to make a decision today, because breast cancer being an emergency that needs to be treated yesterday is also a myth. If you have time to make your decisions, and I always tell them, it's fine if you can't come to a decision today. Go back, talk to your family, come back with your partner, maybe have some time to yourself, sit down with our breast care nurse, and then the breast care nurse feeds back to us and says, okay, she probably told you this, but she doesn't want that. She wants this. So the next time she comes, I'm forewarned, and I would play along with that and play like a devil's advocate to say, okay, what are the benefits of this? What do you perceive as the benefits? And what do you perceive as the risks? And I'd say, right, this is not the right, perception that you've got. It's not right. This is the data that supports this. Some people like data. Some people don't want to know statistics. They just want to know, right, I want to save my breast. Do what you can, save it. I don't want to know the risk of recurrence. So it's very, very customer oriented. It's almost, you have to gauge the mood and then roll out your advice so that you maintain that trust, that bond, that conversation. And it has to be a conversation. It can't be, I'm talking at you. It's, we're talking and let's come to a conclusion. So I think that it's the best way to win trust and to maintain that trust. And then the patient is always happier when the decision is hers, because there is a sense of ownership.
Correct.
To say, right, he's doing what I'm telling him to do, and he's not pushing me to do what he wants me to do, or she.
You just enable the patients to make better decisions, is what
I
you're
think
saying.
that's the best way. Empowering through information is the way forward, and there should be no other way to make treatment decisions.
In this way, they own it.
Absolutely.
That's important because they made it.
Yeah.
It's very important that they own their decision, because 5 years down the line, you don't want someone coming back to you saying, oh, but you told me. So I always think this is not, and the other thing I tell patients to think about, and this is very important for your listeners as well, and women out there, is don't think you're looking down the barrel of a gun. Don't think 6 months, 9 months, 12 months, or a year or 2 years. Think 5 years, 6 years, 10 years down the line. What is it that I want? Do I want my breast? Do I want it reconstructed? Don't I want it reconstructed? What is it that is important to me, but in a long period? Because you're going to live. And it's important to convince them that, although you think it's difficult now,
correct,
you are going to live for another 10, 20 years.
Right.
So think further downstream, what is it that you want?
Yeah.
And then they come back to the decision. Or the other thing, when they're struggling with reconstruction especially, I tell them, go back and make a list of your wants. What do I want? And then which treatment ticks most boxes, and choose that treatment. It makes it very easy for them, because otherwise there's a lot of data that's thrown at them, the clinical trials that are offered. There's a lot going on at diagnosis. So you have to slow things down and give them time to come to a decision and own, particularly like you said, own the decision. And then they go with the flow.
Yeah, it's such an important part of your treatment, because, like you said, if they're living for 10 years, 20 years, and they've made their decision based on what's going to happen in the next year, that's not something that's going to help them eventually. So it's such a huge part of how that journey moves forward. I don't know, Dr. Pram, did you have?
So what is the follow-up? They do the surgery. How often do you see them after that?
So I try and keep hospital visits to a minimum. The reason being, they equate the hospital with bad news. It's not a friendly environment. It's true. It's human nature. Every time they've come to that hospital, they've got more and more bad news. So once the surgery is done, because most of our surgery today in breast surgery is ambulatory, So they go home the same day. They come back to me 10 days after for a wound check. So they looked out. We have this fantastic system where the patients have an app and they can take a picture of their wound and send it back to our wound care nurses. And the wound care nurses say it's fine. Oh, it's a bit red today. It looks a bit angry today. And they send a picture back. And so they have a dialogue. So they're not dependent on the hospital. Then we make them independent, empower them with this lovely app for wound care. If there is any escalation, the nurse will come to me and say, look, I think this is what it looks like. What do you think? Should we call her in? And I always ring up the patient. The first thing is call the patient and say, are you worried? And if you sense that, yes, there is a worry, and no matter whatever technology you throw at her, she needs that face-to-face, I call them in. So that's an intervention which is not planned, but usually 10 days after surgery. Then I'd see them at 3 months to maintain after radiation to look at the aesthetics, if there's any change, if there's anything that I'm going to be planning. 6 months and then a year, and then it's just annual. So that's how especially complex surgery reconstructions, I'd like to see them at 3 months, 6 months, and 12 months, because it's a living, breathing thing, a reconstruction. It changes.
Right.
So I would want to see them then, and then annually they have their mammograms, and we also have what we call a nurse-led follow-up. So it's a remote follow-up where you come in, you have your mammogram, or you go to a center near you, have your mammogram, and we report the mammograms and say they're fine. We don't offer you an appointment, but you can choose when you want to come in. So we don't have prescribed follow-up appointments. We have prescribed mammogram appointments every year.
Mm-hmm.
But other than that, what we call, they're on remote surveillance. So they will control the narrative and say, right, I think I need to come and see you because X, Y, and Z. And if the breast care nurse thinks, yes, it's a valid reason, I can't convince her or answer this on the phone, they come in. So it's not, because you may have a problem 2 weeks after I see you.
Mm-hmm.
And you think, I've just seen him. Should I actually bother him? Do I need to bother him again? There's so much workload, because when you come, you see how busy the clinics are. And you think, oh, there's so many women waiting to see him. So I don't want to bother him. And you leave it. But if you have control saying, I'm going to see you when I want to see you, I think that's the best way to follow them up. So I think we've got this 2 things nailed, is the remote wound care system and what we call remote surveillance, which is, again, totally giving the power back and the control back in the hands of the patients. Absolutely. And they can come in when they want.
Correct.
It's not that because on the 6th of January I have to go and see Ash, they start sweating from the 1st of January to say he's going to find something, he's going to tell me something. But if the mammogram is normal and they don't have any complaints, their life is all tickety-boo, right, you carry on and come and see me when you want to. So at your convenience rather than my convenience.
Right. So this begs the question, Ash. Well, we hear that, many women end up having second and third surgeries for the same cancer, right? And often because margins weren't clear the first time. How does this affect oncoplastic surgery? And is there something you do in your approach to minimize the chances of these repeat surgeries?
No, so I think that's a very, very good question. And, we've got what I call the margin index. So that, as you know, the margins or the acceptable margins have changed considerably.
Okay.
We had a very high re-excision rate up to 2014 when the Americans had the consensus statement and they changed it to no ink on tumor. And that was accepted by the rest of the world. So that brought down the margin re-excision rates considerably. But I think when you're doing especially complex oncoplastic surgery, where you're trying to save a breast which otherwise would have got a mastectomy,
Mm-hmm.
there are a few things that you have to get right. You have to get the planning right. If you don't plan,
Mm-hmm.
you're almost certainly going to fail. So for me, failing to plan is planning to fail.
Okay.
So you need proper imaging, an understanding of the imaging, a discussion if you need to do with the radiologist to say, is this all I need to remove? Are you happy with this?
Mm-hmm.
Do I take a shave from here? Try and plan it in such a way that you have mapped out in your mind 3-dimensionally what part of that breast needs to come out. That's one. Then if it's impalpable, if it's more than one area, how am I going to localize or ring fence this in such a way where I can't feel it? So it has to be guided. So am I using the right localization? Is there some AI? Is there some fancy tool I can use to help my surgery? Then you need to have a clear, at the time of the surgery, we use intraoperative imaging. Because if it is not occult on X-ray, I would use intraoperative imaging. Make sure I've got all the microcalcifications of the tumor, the margins look clear. You now have three-dimensional modalities of imaging or tomosynthesis. So I think that is very helpful, and there's clear advantages over 2D. There is also a good discussion to be had with the pathologists about margins, specimen orientation, because oncoplastic surgery, you don't want to go back in. It's not like the old cancers where you went in and you found a cavity. What you've done is painstakingly reconstructed that cavity, moved tissue around. And unless you have a detailed map, which I draw for every patient, you might end up taking the wrong bit and then have the false reassurance that, yeah, the cavity is clean. So it isn't just about better cosmesis, it's about getting it right and getting even wider excision. So oncoplastic surgery allows us to do that. It allows us to take wider margins. I know that in America, they take shaves. So they take the cavity out and then they take margin shaves. So from the radial margins, they take further cavity shaves. And that reduces the risk by about 50%. So everything that I can do, I want to do, because going back is not just about health economics. It's to do with patient anxiety.
For sure.
It's to do with theater scheduling. And it's to do with cosmesis. Because I have put right the cavity I created the first time around. Suddenly now I'm getting a bit more greedy and taking bigger chunks out. Am I going to have that lasting cosmesis following radiation therapy? Because what people forget is radiation therapy, although it has a huge amount of benefit, also causes a bit of fibrosis and scarring. And fibrosis and scarring is like cement. It just draws things to itself. So any imperfections that you've left, which are subtle before you start with radiation, become amplified post-radiation. So every time you have to go in and take more tissue without being able to reconstruct that defect, you're going to be faced with a problem. So get it right the first time. Try and reduce your margin errors. I know in a lot of countries, including India, they use frozen section, but that has its own drawbacks. It's very expensive. It's very resource dependent. So there are lots of ways of using it. There are lots of new technology coming in, very exciting, about using radio frequencies, using confocal microscopy, using optical spectroscopy. All these are now being used, and it's being developed in a huge way to try and reduce this re-excision. We are trying to work towards no re-excisions. We've got it down to less than 10%, which is what the American colleges say. I think credit is due where credit is due. The American colleges is the only college across the globe that has said that an aspirational re-excision rate should be less than 10%.
Amazing. Okay.
So you've got it right there. We just need to roll it out in Europe a bit.
Yes. What are you the most excited about when it comes to the new reconstruction techniques or even the technology that's coming in?
So of course there is. Let's start with the basic stuff. So we've got new generation implants. You've got now having biodegradable implants that are just being trialed. So instead of silicone, you'll have a scaffold which will eventually in 18 months absorb, but you inject fat into it. So with fat grafting or what we call fat engineering, you will be able to recreate the patient's breast without big flaps and fancy autologous reconstruction by just using absorbable tissue scaffolds.
Amazing.
You also have new kind of meshes coming in. You have bioengineering where we have engineered tissue that you can use, which will hasten healing, will reduce scarring, will reduce fibrosis, will fill the cavity. So less is more. You've got a lot of things happening in the space of chest wall perforator flaps, partial breast reconstruction, using fat grafting at the time of partial breast reconstruction. So there's a lot of new technology coming in, and then there's AI. How can I forget
Correct.
AI? Because AI is going to help with, because patients always ask you, how am I going to look after this? And it's very difficult. Even if I was William Shakespeare, I wouldn't be able to explain how, put it in words about how it's going to be. And like have said, pictures say 1,000 words. You now have nice 3D AI-driven models that will show the patient, this is how you're going to look. So they take a picture of the patient rather than someone like the patient.
Wow.
And say, okay, post-reconstruction, if you choose a 350cc implant, this is how you're going to look. But if you want to go a little bigger, this is how you're going to look, but then we need to do surgery for the opposite side. Or an autologous reconstruction. We use AI to tell us about skin quality, to look at the breast density, to tell us about, we have ICG coming up. So we've got nice imaging modalities for skin vascularity, blood supply. So there's lots happening in this space, and robotics, minimally invasive surgery, robotic mastectomies. And the biggest thing that's happening in America is sensory or sensation preserving mastectomies. Because that mastectomies, they usually lose sensation.
Yep.
But with the neurotization, with the neurotization techniques that are being led in America, they're using nerve grafts, they're using patient nerves, and giving you back sensory breast. So not only do you have a reconstructed breast, you still have your sensation. So that's really exciting.
So a lot of things happening in that world where this, the whole treatment plan will change almost with the way things are going.
I think surgery is, and it pains me to say this, it actually pains me to say this, but surgery is at risk of becoming an adjuvant therapy because you're going to get so much of precision medicine, next-gen sequencing. You're going to get genomic guided treatment. You'll be able to tell soon which drugs will act on which patients, will be more efficacious in which scenarios. Biology is king. Techniques are becoming second-class citizens, unfortunately, and that's where we are. So we already have a trial coming out of MD Anderson, albeit a small trial, 50 patients, high risk, triple negative and HER2 positive patients, where the patients actually skip surgery altogether.
Amazing.
So small cancers, 50 patients, didn't have surgery, didn't have sentinel node biopsies, had radiation, and they're doing 5 years down the line, they're doing really well. So it may be that in certain cancers, we are just going to be bystanders and watchers and not taking an active part in it anymore.
So,
and that's good. I mean, I don't think that's a bad thing.
Improved outcomes without...
It is going to improve outcomes, yes. And that's the best thing that we can hope for as surgeons, is to have a complete response where we are not needed, or we're needed to minimal surgery just to tell us that, yes, there's a complete response.
Okay. That's amazing. I think that's so empowering to a lot of women who are...
It gives them courage and hope.
It does, because triple negative breast cancers, HER2 positive breast cancers, a few years down the line, they were the worst cancers to have.
You're right.
But when women heard triple negative breast cancer, they used to go into the shell and say, oh, I'm going to die because I need chemotherapy. If it doesn't work, that's it. But now with the advent of immunotherapy, with the newer drugs, with olaparib, with capecitabine, you can actually get a complete pathological response in close to 65% of patients.
That's
so
amazing.
If you had 100 women and they all had chemotherapy and pembrolizumab, which is the immunotherapy, 65% of them won't have cancer left in their breast. Which is amazing considering to where we were 10 years ago. With HER2 positive breast cancer is the same thing. If you give them dual blockade with Herceptin and pertuzumab, 65% complete pathological response. There's de-escalation happening in the axilla, where we had a previously positive axilla. We don't clear it anymore because the cancer in the breast has gone. The cancer in the axilla has gone. So we brought down things like lymphedema. We are actually, the less is more concept is here to stay, and we are seeing proof of it every day. So it's a very good thing and a very positive for women there who are just been diagnosed or are going through the treatment, that there is a lot of hope out there, and the landscape is changing really, really fast.
Completely. Yeah. Dr. Pram, you had some question about lymphedema, right?
I did. Well, when you're doing reconstructive surgery or oncoplastic surgery, do you also go into the lymph nodes, or it's just aesthetics?
So oncoplastic surgery primarily is for the breast. So with surgery, there's two aspects. We need to remove the cancer with a clear margin, But we also need information from the axilla or the armpit to tell us whether certain treatments will add value. So they call it staging operation. So we need that information from the axilla. Now, previously, if you had one node positive, you had to clear the whole axilla, which would then increase your lifetime risk to lymphedema to between 15 and 20%, and some centers even say 25 to 30%. So let's accept a happy mean of 20%. So you have a lifetime risk of lymphedema of 20%, which is not small.
No.
It's a significant risk.
Right.
Correct.
Not only because the most talked about risk of axillary clearance is lymphedema, but you also have sensory loss, sensory changes, you have neuropathic pain, you have shoulder function impairment.
Right.
Nobody talks about this. Lymphedema is center stage, but if you look at the global morbidity surrounding surgery to the axilla and complete axillary clearance, you have, three things to consider: the lymphedema, the sensory compromise, and the functional compromise of the shoulder. And these can last forever.
It's true.
So what we want to do is de-escalate what we do in the axilla. And two fantastic trials that came out some time ago were the ACOSOG Z11 and the Amaros trial, which showed us that instead of removing all the lymph nodes in patients who have one or two lymph nodes that are positive, if we give them radiation, we can reduce the problems by half. So we de-escalated surgery there. In patients like I just mentioned, the triple negative breast cancers, the HER2 positive breast cancers, if you have a positive axilla, we clip the axilla, and then we do a targeted axillary dissection where we remove the clip node, which was previously positive. And if that is negative, we don't proceed to an axillary clearance. So we've de-escalated the post-neoadjuvant therapy. In the small chance where we need to go and clear the whole axilla, we now have a procedure called lympha, which is the lymphovenous bypass that we do. Because we know that when lymphedema is present, it's manageable, not curable. So what is better than prevention? Nothing. So if you anticipate a patient who's obese, who's had neoadjuvant chemotherapy, who's going to have radiation therapy to her supraclavicular fossa, you can use this lymphovenous bypass or lympha procedure intraoperatively, which is a supramicrovascular, and create a bypass between the lymphatics and the blood vessels. So you're creating a shortcut and trying to reduce the risk of lymphedema. And that there was a randomized controlled trial that came out which showed that if you do the procedure, you have a lymphedema rate of between 8 and 9% as compared to between 20 and 25%. So it's a substantial reduction by doing this one additional procedure, which adds about 40 to 45 minutes to the operation.
Wow.
But
okay.
Where is 40 to 45 minutes? If you compare that patient with lymphedema, she'll come back to clinic every day.
Right.
For the rest of her life. She'll require bandaging, she'll require skin care, she'll require psychological care. She might require assistance with even dressing and stuff for that. If you look at the whole healthcare cost of that compared to a 45-minute operation, I think it's a no-brainer.
Right.
True.
So doing the surgery meticulously, and when trying to first avoid the whole clearance, and when you have to do the clearance, do it in a nice way where we leave the fascia of the vein intact. We try not to go crazy, and where we need to do reconstruct the lymphovenous bypass.
That's a lot to consider.
It is, and that's where we come in. No, that's why we are making those decisions for the patients, and most of these decisions happen when the patient's asleep, because when we do the central, we've done the nodes. Sometimes if you do a frozen section, you get one positive, but otherwise we do a central lymph node biopsy, and then the patient comes back and we tell them, okay, it's one node out of 3, and we don't need to clear the axilla. So
do you think that this concept is changing around the world? I know there's a lot of work done in America, but what about India? How does that all fit in?
So I think you've actually caught on a very, very important point, which is the disparity of healthcare across the globe. One of the reasons why I'm in India is to try and do my little bit to try and bridge that gap. It's not a gap, to be honest. There is a bit of a chasm. It's there. The problem is in the West, most of our patients, so more than 50%, 60% of our patients will come with stage 1, stage 2 breast cancer. As opposed to where I am now, in the developing world, you have 50 to 60% of your patients coming with stage 3 and stage 4 breast cancer. We need to reverse that. And that is going to happen through education, through governance, through government legislation, and through technology. We need to get these three singing from the same hymn sheet. Although
And
they
early
pull in different
detection.
directions.
And early detection.
That's where I was coming to. So
Okay.
if you have patient education, patients will bring themselves for early detection, will learn how to examine themselves. They know that it's very important to stress what you've said, is what is taken for granted in the West. You have a population-based screening system. We don't have anything resembling that in India. The reason being, it's a massive amount of population. The Indian population is the population of Americas and Europe put together. So there is no healthcare system in the world that can provide for such a massive amount of headcount.
Mm-hmm.
So we have to look at educating women to examine themselves. When there is, the vans come to the villages to go and avail of the mammogram, to echo concern, to raise concern if there is a problem, to be empowered enough to raise concern. Small cultural gaps like breast cancer is still a stigma. Because if I tell the world that I had breast cancer, no one will want to marry my daughter. In fact, I was actually today, one of the patients told me something fantastic, which actually blew my mind. So he said, you know why the Indians ask for 4 generations of names and family names? So I said, no, why? He said, because if there's a genetic mutation, it can't skip 4 generations. So if there's a BRCA mutation, it'll skip 1 generation. It might skip 2 generations, but you will find it. So I want to know if anybody in this family had cancers, with heart problems, had dementia, had Alzheimer's. And that's why in Hindu mythology, they ask for 4 generations of names and they go back 4 generations and check your health. So
I
they
didn't know that.
this is rudimentary genetics.
This is amazing.
It's amazing how people know this because, but now we're kind of putting it back and relating it to science. So we need to know genetics, educate them that if there's a cluster of cancers in your family, come forward.
Yeah.
We need to kind of do something about it. So early detection comes through that. Genetics will play a role. Patient education, patient empowerment plays a role. Access to healthcare, to drugs, to surgeries, to immunotherapy, that'll come through legislation. So we need all those synergies to come together, and that'll only happen through legislation. Unfortunately, there is only so much that charities and NGOs can do.
Correct.
At the end of the day, the government needs to take responsibility for its population.
Also, it doesn't matter, access, so in the West, because everybody has access to care, that doesn't exist so much in a country that's developing at this moment.
That's so well said. Even if there is access, there is a bit of reticence. Who'll look after my family? Who'll go and plow my field?
Right.
Who'll reap? Who'll go and reap the crop?
Right.
All these things, and cost. Uncertainty about, okay, once I sit on this roller coaster, how much is it going to cost me? And I can tell you for a fact, when I was in Tata Hospital, we knew of families that sold their houses and sold their fields to pay for treatment. And then the patient dies. So I always said in India, it's not a disease of an individual. If it happens to the lower socioeconomic class, it's a disease for the family. Where the whole family pays the price.
Correct.
So it's a very hard hitting, to see these poor people come through the door, and they're trying to do the best for their mothers or sisters, and they sell everything they own.
Right.
And that's still not enough because the cost of medicine is so prohibitively high today. We talk about these fantastic results with pembrolizumab, but if you put pembrolizumab at cost, it costs more than a junior doctor makes in a year. Just the delivery of the drug. That's one drug. Forget chemotherapy, surgery, and radiation therapy.
Right.
I'm just talking about pembrolizumab.
Yeah.
So there's a lot of disparity that is there in how the healthcare systems work, access, education. We are getting there slowly.
Yeah.
But it's such a big Titanic.
Yeah.
India
Yep.
is a huge ship to turn around.
Mm.
And it's coming across 1 degree at a time. It will come across.
Yeah, I think this is eye-opening overall to see what the fundamentals of the disease are, and also what care looks like in different parts of the world. We know what it looks like in the US. Ash has worked both in Europe and now in India, so you
Asia.
have a global view, in Asia.
So I think if you have money, Asia is the best place to fall sick in, because you can get healthcare in a day.
Right.
So if you can afford it, the best place to be in if you're not well is in a country like India.
Interesting.
But if God forbid you can't, or you don't have that kind of
Money.
wealth at your disposal,
Yeah.
then it is a nightmare. And I have to be the first to admit it, that this needs to change. And like I said, that's why I'm trying to do my little bit.
Right.
In terms of patient education, webinars, I have focus groups. We've organized all that happening. I go out in the community, give talks. I try and get those people who are sitting at home to to tell their families, because you know how India culturally, women are still shielded. It's a very patriarchal society. Women are still shielded. Families make decisions for women.
Correct.
And Preeti, you come from the same background as me.
Yeah.
You know how it works. So, you sit in front of a woman, and it's the father-in-law, the mother-in-law, and the brother-in-law who are making the decisions for her. And the poor thing doesn't have a say.
Correct.
So we need to change a lot. And it will change.
Yeah.
And thanks to social media, and everyone's now got a mobile phone. So, things like this conversation itself will have an impact.
Absolutely. And this is why I'm doing this whole series, is to,
And I applaud you for that. I think it's great that more and more people should come forward and do this, because it's through things like this that people will watch. I can give you a prime example of this. Was a woman in a village saw me talking about reconstruction. Now, she came to my clinic.
Right.
She knocked on my door and said, I can't afford this, but I
Right.
want it.
Right.
So I work in a very good foundation trust. And I went to the governors and I said, look, there's this woman. She's only 40 years old. I can't take her breast off and not reconstruct it just because she doesn't have money.
Right. Right.
And they said, fine, do it. We'll pay for it. So she had all singing and dancing reconstruction. But again, this is one woman. We're talking about a population that doesn't probably have access.
Yeah.
Less than 1% of women in India get a reconstruction. How appalling is that?
And that's amazingly appalling. I mean, I can't even imagine living that kind of life, especially in the West. Forget about it. That's like not even thought of anymore.
Exactly. So I come from a breast unit in the UK where we were the largest reconstructing unit in the UK. 73% of our women who underwent a mastectomy had an immediate breast reconstruction, and the ones that didn't either chose not to, or were oncologically not sound to have one, or then they had high risk factors like smokers. Now fast forward to India 2025, 1% of women undergoing a mastectomy. Let's say I'm wrong, it's 2%. Let's give them 100% benefit of doubt. 2% of women getting a reconstruction is appalling. 60%, 70% mastectomy rates, when breast conservation it's the opposite. You have 70 to 80% breast conservation, 20% mastectomy. Here we've got 60% mastectomy, 40% breast conservation. We need to change a lot. And this will only get through messaging, where patients should feel empowered to say, hang on, why do you want to take my breast off? Why can't you just save it?
Right.
Haven't you heard of oncoplastic breast surgery?
Absolutely. And I think this is the important part, that, most women, even in India, if we can send this message through this mode, telling them that please ask these questions. I mean, these are important questions to ask, whether it's your surgeons, whether it's your, treatment plan, or even convincing your families that this is a better way to do this. So, I mean, that this is the reason we're doing this, so that people like you can actually talk to their patients as well, in a generic possible way that they understand, and they can even share it with their families.
I think also the cost of these things. People are afraid to give up their farm and their house and their jewelry and everything not understanding what that means or the outcome of which could be difficult.
You're right. I mean, I don't grudge pharma for the research that they do in the millions and hundreds of millions of dollars they spend on research. But there has to be something which says, all right, for every 100 million you make, give 5 million back in terms of free drugs. It's a legislation, a simple act of legislation can say, and credit to India, they've actually done this. It's called corporate social responsibility. And within corporate social responsibility, you have to give 2% of your gross turnover back to charity. Okay. And it's very, very well defined and well governed charity. So small things like this where we say, right, you can only, there's only so much money you need and only so much you need to gratify your shareholders. You have to give something back when you're making this kind of money. Okay, we won't tax that bit of your money, but just give it back. Some things like that need to come in because, regardless of where you are, the West or in India.
Sounds like India is very progressive.
It is progressive and it is changing quite rapidly. But the problem is we've come from a big handicap. We've got a long way to catch up.
Correct. And I feel like, the important part is women supporting women more than anything else overall.
I think that's the biggest.
It plays such a huge part in everything.
It has to be. The message has to go from woman to woman. It has to be that. There has to be an absolute cascading down of information. Women to daughters to sisters, mothers talking to their children, grandmothers talking down, and then early priming of this. Look after your bodies. Try and prevent breast cancer.
Correct.
Cut down, try and live a healthy lifestyle. Quit smoking. Don't drink too much alcohol. Have your exercise. Eat healthily. Watch what goes in. Control your weight. All these things are so important where we can actually prevent breast cancer. We can't 100% prevent it, but we can probably reduce it. So it starts from prevention to early detection to treatment to delivering the right treatment to the right surgery. It's the whole spectrum.
Correct.
And you've got most of it right in the US, except obviously few things with the prevention bit. But but you've got the other things nailed down to a T.
Right.
Where we're struggling is right across the spectrum.
Correct.
So we need to kind of up our game in a big way to even come close to that kind of survival rates and the quality of life and the patient satisfaction that we are talking about that comes from the West.
Right.
I don't think anybody here is even talking about patient satisfaction.
I mean, I don't think that's a consideration at this moment even. As long as you live, that's like, that's your bonus.
Yeah, you should be grateful you're alive. I think that's the wrong
attitude.
That's the wrong message, but yes, it is. Unfortunately.
Yeah. As we close this conversation with you, Ash, what is a message that you'd like to give young women, older women, whoever it is that, you kind of deal on a daily basis with?
I think the one message that we have to do is to get to women is remember you're not powerless. Things have changed. Breast cancer today is far more treatable than it was. It's not a single disease. So if we tell you that you need chemotherapy, it's not a death sentence. It means that we're trying to improve your survival through multidisciplinary care. Today, most treatments will require a bit of surgery, a bit of radiation, some immunotherapy, endocrine treatment, and maybe chemotherapy or targeted therapies like antibodies. But all this is being done because we've now recognized that breast cancer is not a single disease. It's not a one-glove-fits-all disease. It's a heterogeneous disease. Every cancer is different. A 32-year-old woman with ER-positive breast cancer has different needs to a 72-year-old who has ER-positive breast cancer because that 32-year-old wants to have a family, wants to get pregnant. The 72-year-old is happy taking whatever you give her for as long as you give her. But this one is going to come, the younger one's going to come back to you and say, I want a family. So thanks to certain studies like the positive trial, we now know we can interrupt that and they can have children and then go back on their treatment.
Right.
So if the diagnosis does come, I think the message should be face up to it. get good health care, demand good health care. I think that's more important. It's not an option anymore. I think you should feel empowered enough to go to the best, to seek the best for you. Voice your concerns, question advice in a nice way. So it's not a contest, but if you don't agree with something or something doesn't fall within your values, be more than empowered enough to say, right, why do you think this is important? This is good for me. I don't think I want this, but if you can convince me that this is better for me, I'll have it. There is always a way through. Voice your concerns, because if we don't know, we can't address those concerns.
Correct.
Ask, there is a lot of help available.
It's true.
So there is help around everything, around issues with pain, around issues with mobility, around issues with intimacy, around issues with side effects to drugs, to endocrine treatment. Everything, unless it's raised, will not be addressed. So cancer is not only curable, you will come out the other way, the other end smiling, we'll give you your life back. But it's something that we need to pick up early. We need to give our good stories also a bit of airing to say, I had cancer, I beat it. Because everything that's on the internet today is I had cancer and my doctor missed this and this happened to me and I didn't do well and look where I am today. You've got all those horror stories out there. But the good messaging, the positive messaging needs to be transmitted from woman to woman, like we said. It needs to be out there to say, guys, this is beatable. Let's just tackle this head on and deal with it in a way that's best possible. And then we will get the outcomes that we want.
I love how positive this whole podcast has been. I really want to recommend that people or women educate themselves so they feel empowered to ask the questions so that they can advocate for themselves, and not only that, but receive the best treatment possible so their outcomes are better. And because a woman supports a whole family, if something goes wrong with a woman, the whole family is suffering.
Correct.
So it's important for that messaging to go out overall, whether it's to younger women or it's to older women. I think the message is still the same, that hold your truth. It's important.
Absolutely.
Thank you, Ash. Thank you very much for being part of this.
Thank you both.
Thank
it was
you.
lovely talking.
It was amazing, and I really enjoyed it. Enjoyed the conversation, the interaction. Yes.
Thank you very much, Ash, for your time.
Thank you. Thank you for doing this. Thank you.
Have a good one.
Bye-bye.
Bye.
Dr. Kothari, thank you for sharing your experience, your expertise, your compassion, and your vision for the future of breast cancer care. This episode will empower so many women to ask the right questions, understand their options, and feel less alone. To everyone watching, please share this conversation with someone who may need it. Your comments and your stories help more women find this information enlightening. Don't forget to like us, subscribe, and follow the Mood Food Podcast for more conversations that blend science, healing, and the human spirit. Thank you, and we'll see you in the next episode. Goodbye.